Welcome to this GSA Momentum discussion titled Kickstarting Brain Health Conversations with Diverse Older Adults, Challenges and Opportunities. GSA Momentum discussions highlight topics experiencing great momentum in the field of gerontology. We're grateful to Genentech, Lilly, Otska, and Eisai for their support of the GSA KAER Toolkit for primary care teams and this momentum discussion. My name is Jen Pettis, and I'm the Director of Strategic Alliances at GSA, and I'm pleased to serve as the moderator for today's momentum discussion. I'm delighted to be joined by Dr. Carl V. Hill, the Chief Diversity, Equity, and Inclusion Officer at the Alzheimer's Association, and Michael Splain, a principal with Splain Consulting and managing partner with Recruitment Partners, LLC. I'm also joined by Dan Stewart, the Deputy Director for the Aging Equality Project of the HRC Foundation. And finally, I'm joined by Lisa Combs, a Service and Support Advisor for the Ohio Association of County Boards of Developmental Disabilities. Welcome, everyone. I'm so glad that you could join me today. The topic of brain health as an important aspect of overall health should be addressed with older adults during any office visit, including the annual wellness visit. However, all too often, patients expect that providers will raise the topic while providers are waiting for patients to bring up any concerns. Brain health discussions are particularly important in groups which prevalence of Alzheimer's disease and dementia are particularly high, such as African Americans and Hispanics, who are 2 and 1.5 times, respectively, as likely to have Alzheimer's disease than their non-Hispanic white counterparts. The vital first step in the GSA KAER, or Kickstart, Assess, Evaluate, Refer framework is to kickstart the conversations. The tools and resources in the Kickstart section of the GSA KAER Toolkit for primary care teams supports the teams to discuss brain health, observe for signs and symptoms of cognitive impairment, and listen for patient and family concerns about cognition. During this momentum discussion, our panel will discuss challenges with kickstarting brain health conversations with older adults from diverse and underserved communities, and they'll offer opportunities and solutions to use tools and resources in the GSA KAER Toolkit for primary care teams to enhance brain health conversations, drive healthy brain habits, and promote early diagnosis of dementia in these communities. Let's start by setting the stage for our discussion today. I'd like to ask each of you to share some background information about disparities and challenges that exist and underlying factors that may drive those issues. Carl, with its 2021 Alzheimer's disease facts and figures, the Alzheimer's Association issued a special report examining race, ethnicity, and Alzheimer's in America. In the report, the association identified many disparities and what factors may be driving those disparities. Can you share a few key insights from the report?
Absolutely. Thanks, Jen. Yes, this was the first national generalizable survey to assess differences in racial and ethnic attitudes towards care. And so the association worked with Versta research company to conduct surveys of U.S. adults and current or recent caregivers of adults. And I tell you, we found some really interesting findings. First, discrimination is a barrier to Alzheimer's and dementia care. More than 1/3 of Black Americans and nearly 1/5 Hispanic Americans and Asian Americans believe that discrimination would be a barrier to receiving Alzheimer's care. And then, half of Black Americans report that they have actually experienced healthcare discrimination when seeking care. So it's really important, knowing that there are FDA-approved treatments that are designed for people in the mild cognitive impairment phase of dementia, and knowing that these populations who are disproportionately affected perceive and have experienced racial discrimination is a real important finding. Here's another finding from that special report. People of color want healthcare providers who understand their unique experiences and backgrounds, but many doubt that they would have access to culturally competent providers. And so here, an overwhelming A majority of non-white Americans, participants in this survey, said that it is important for Alzheimer's and dementia care providers to understand their racial or ethnic background and experiences. And fewer than half of Black and Native Americans feel confident that there is access to providers who are culturally competent. A real call for action, I think, for training more neurologists from Hispanic serving institutions or historically Black colleges and universities, and certainly elevating the level of cultural competence training for all providers. And I'll give you one last one, Jen. Black Americans lack trust in research clinical trials and have doubt that advances in Alzheimer's treatments will be shared equally. So here, nearly 2/3 of Black Americans believe that medical research is biased against people of color, and Black Americans are less interested in participating in clinical trials. So this is a real, I think, really important finding, because we know the severe lack of representation in Alzheimer's clinical trials research. We know that the 2 FDA-approved treatments had very few non-white participants. And we've got to do our work as it pertains to trust, to be out in communities, to talk about the importance of participating, to making the trials practical so that people can participate, thinking about transportation and ease of participation. So we're really excited about what we can do in community using these data to really help us develop practical outreach and engagement activities that can help us pursue health equity here, Jan. Yeah, thanks so much.
Thanks, Carl. You mentioned a call to action, and I think we're perhaps having that here today as well, looking at challenges and opportunities for diverse populations. So I'm so appreciative of all your time and perspectives. And Dan, I'd like to switch gears and talk with you a bit. If you could share some of the challenges that the LGBTQ plus older adults face concerning aging and brain health and dementia.
Well, this is a vibrant and growing community. We see nearly 3 million individuals over the age of 50 who identify as a sexual or gender minority, or LGBTQ+. And if we look at the researchers at the helm of this research body, we actually estimate that number might be even double right now. But because of a history of stigma and legal discrimination, this is a population that has historically for decades avoided care. It's important to recognize in terms of the systems that the first diagnostic and statistical manual of mental disorders in 1952 categorized homosexuality as a mental illness. It wasn't until 1973 that was removed. So if you think about a coming of age of the elders that we see today, for much of their life, the medical community was stating that their identity was pathology. And so with the compounding years of avoiding access to care or even finding care that may be culturally sensitive, often what we're seeing then, unfortunately, is almost a progressed biological aging of this population, where we're seeing higher levels of chronic illness, chronic disease, diabetes, heart disease, things that we know are factors that really can increase that risk of dementia and cognitive decline. And so when we think about brain health, thankfully, we're starting to see some research and large-scale research. In 2019, we saw really for the first time some landscape research showing the prevalence of dementia within the LGBTQ community. But I think what's most important, especially as we talk about brain health, is that our LGBTQ older adults have a higher subjective cognitive decline as they age compared to their non-LGBTQ counterparts. And as we learn about the data and the information as it relates to people of color, many LGBTQ people identify as LGBTQ and a person of color. And so when we start thinking about intersecting identities that can really compound some of this marginalization, how we see it play out often is how our older population is aging. And so that avoidance of care, fear of accessing care, again, within a historical context, really painting the picture of, as we're kind of theme building within this conversation, of a call to action, and thankfully actions that we know can be impactful within this population. So just I think really from the utmost importance is also just even recognizing this population. I think we are all centered regardless of discipline in person-centered care. And so ensuring an opportunity to ask about those individuals' identities to really know what they're up against.
Mike, the American Indian and Alaska Native people have long experienced lower health status when compared with other Americans. How about brain health in this population? What disparities exist and what challenges do we need to overcome to promote brain health in this population?
So I'm not a tribal citizen. Let me say that up front, but I have been working intensely with this community about these issues since 2019. So what are some of the challenges? There's as much diversity between 574 federally recognized tribes as there is between American Indian, Alaska Native tribal people and the white or majority population. So there's diversity within this community, and it's hard to generalize. But I think brain health is also complicated by the fact that there is, particularly for reservation living Indians, there is a fundamental inequity in access to health care. The Indian Health Service reports regularly to Congress that they have about 20% of the money that they need to meet their mandates for reservation dwelling Indians. So there's that disparity. I think culturally, there's been more acceptance of dementia, losing one's faculties at the end of life as normal aging. And I think we've seen this in every population that's come along dealing with dementia, is that at first it's accepted as normal aging, and then realized that no, there's something. As we have more and more older people, we see this divergence between people who may have thinking problems and people who have thinking problems that are severe enough that they need attention. What kind of attention can people get? Access to specialty care and other ways of classically dealing with diagnosing and identifying people with some form of irreversible dementia may be very, very difficult. One more diversity to throw in there is the fact that about 60% of people who identify as American Indians or Alaska Natives live in urban areas. So we've got urban dwelling American Indians, we've got reservation dwelling American Indians and Alaska Natives. It's a diverse population. It's not all crisis. Let me just say there's some energy going on that's quite exciting. And there's some ways to camp on. For example, there's a massive rejuvenation of a traditional foods movement within Indian country, and with some very good people behind it, some good energy, some money, some identification with it as a fundamental problem, that access to traditional foods may be part of why American Indians have such poor health, and grafting brain health into that traditional foods movement. I don't know what the opposite of a disparity is, but that's an opportunity. So it's a mixed bag.
Thanks, Mike. That's great. Lisa, certain groups of individuals with intellectual and developmental disabilities develop dementia at rates similar to older adults in the general population. However, older adults with certain conditions, such as Down syndrome, develop Alzheimer's at greater rates. Can you share some insights into brain health disparities in this population and some unique challenges that we need to address to improve brain health and early detection of dementia for individuals with intellectual and developmental disabilities?
Absolutely. Thanks, Jen. Wow. I wish I could just like clone the conversations that, Carl and Dan and Mike just did. You guys all brought up issues, that we all share. And I think that's probably one of the biggest things is that, people that are LGBTQ or people with color and obviously American Indians and people with disabilities often go through all of these they're all struggling with all these issues many times. So some of them are similar. I think specifically with the IDD community, there is definitely, well, first of all, I am not an expert. I am a parent and a DD professional. So please don't anybody come back and say, she said, I'm in Ohio and I know what I know from experience. But, you know, from the research I've done and the groups I've been on, I've learned that obviously folks with Down syndrome do have a very greater likelihood of developing dementia, to the extent that by the time somebody is in their 60s with Down syndrome, that, you know, anywhere from 60 to 90% of those people are diagnosed. So that's a huge challenge for us. And you know, that ties right in with the fact that this is somewhat of a new thing for people with IDD, because people didn't live as long in the past that had kind of multiple disabilities and intellectual disabilities. And so we never really thought about people living into their 50s, 60s, 70s. I mean, in Ohio, we just had somebody with their 100th birthday who's living in a supported living setting. And so that's great. Like you guys said, there's really good things going on, but so it's pretty new. I think there's some data that shows that, you know, since the difference between 2002 life expectancy compared to 2030 is like, we went from 600,000 people living past 60 to over 1.2 million. So, you know, it is new for us. But I think that we do have some of our challenges are very similar to what you guys all brought up. Healthcare disparity is a big one in the community for IDD. Physicians in general, you know, I actually am on quite a few committees in Ohio with physicians, and there is kind of this feeling that we don't know what to do when somebody has a disability, an intellectual disability. They might not be able to answer the questions. They might not, you know, we don't really know where their baseline was. And so we don't really ask a lot of questions about intellectual, you know, where they're at intellectually or their brain health. We just don't ask. We just assume, oh no, that maybe their brain health isn't good. The diagnostic overshadowing, Jen taught me that. I'm going to use that word today, Jen. Thank you. That is probably the biggest issue that we do have in the disability field, because of people they struggle their entire life with discussions about brain health. They don't know they do, but from day one, we're worried about their intellectual functioning. We're worried about their communication. We're worried about their physical. So as you move through aging, identifying those differences become more and more difficult. I think the good news about I know there's one other thing before I talk about the good news, and that is, I think the other big challenge for us is that so many people with disabilities live with aging parents. And so we have, or they live with caregivers that are paid. And either way, the aging parents have a hard time picking up on changes. Some of their parents have dementia or Alzheimer's, are dealing with their own issues, so they may not be good reporters of changes. And then if they live with multiple caregivers who might be paid, they have people coming in and out, and the staff is changing constantly. So that is a challenge for sure. But there is good news, just like Mike said, right? There is good news on the horizon. We have a lot more knowledge that people with disabilities are developing, these are living longer. And we are, it's actually a godsend. I wrote down that, you know, one of our godsends is that we have a provider pool in caregivers that we can actually, we have a lot of people taking care of people already. And so we just need to help make sure that they understand how things might change as people age and their brain health, and how to report that out. So I feel really blessed about that. I think that's all I got.
Great. Carl, you mentioned one of the findings in the report, and that was where the non-white respondents said how important it was for Alzheimer's and dementia care providers to understand their ethnic or racial background and experiences. And this is such an important issue when we talk about, we talk at GSA about kickstarting brain health conversations. So really that first step in the care framework. What advice do you have for care providers seeking to become more culturally competent? And are there Alzheimer's Association resources that they can look to?
Yeah, thanks, Gina. You know, I tell you, that was the second part of that statistic from the special report, Race, Ethnicity, and Alzheimer's in America, where we asked respondents the reason, you know, that they felt that they were being discriminated against in the dementia care system. And the number one reason for, you know, those non-white respondents was that they felt like they weren't being heard. right? And so could you imagine being a caregiver or, having yourself, memory problems and wanting to discuss that with your provider and having the feeling that you were being disregarded or you were not being heard, right? And so, one overarching, I think, theme here is, one of humility, listening and, being aware of the opportunity to to listen, and show, not only cultural competence but cultural humility, which I think is something that we all, can pay very close attention to. As it pertains to specific resources that the association has, we have a wonderful resource that is our website at alz.org. And right there, you can click on resources for professionals, and you can get a sense of what our dementia care practice recommendations are, or practices for transforming quality dementia care. And I mention these specifically because an overarching theme for all of these resources is humility and cultural competence. It's embedded within the resources that we have. And we also have pathways to dementia care training and certification. And one that I'll point out specifically, Jen, is our project ECHO. It's the Alzheimer's and Dementia Care ECHO program, which connects dementia care experts with professional care providers in a free continuing education series of interactive case-based video conferencing sessions, right? And so you can go on alz.org to get a sense of all of these, I think, products that are developed with professionals in mind, but with the overarching theme of humility and developing competence. I mean, there's a real opportunity to get better here. Once we all understand and acknowledge that listening, showing humility in this space is so critical and important for those who deserve quality care. Thanks, Jen.
Thanks, Carl. And I just want to acknowledge I'm lucky enough to be a volunteer board member here in New York with the Alzheimer's Association, and want to acknowledge how wonderful the local chapters are doing, connecting with their communities, connecting with different groups in their communities, and to give a shout out for folks to remember their local chapters as a resource as well. So Lisa, I'd like to turn back to you and talk about the second step of the CARE framework, and that is assessing for cognitive impairment. What are some best practices for obtaining baseline function for people with IDD? And could you also share your thoughts about some ways to deal with obtaining information from a person with ID or DD if at baseline they have the significant communication or verbal impairments?
Yeah, sure. Thanks. Wow. Baseline is where that is what we need. And it's important no matter who you're talking to, I'm sure. But at the same time, like I said earlier, for people with ID and DD, it really is important, and we don't always do a good job of it. So luckily, the National Task Group on Intellectual Disabilities and Dementia practices has developed a really great assessment tool called the NTG Early Detection Screening for Dementia. And I've been fortunate enough to work with NTG on, learning some about that. And I've had some really much smarter people in Ohio teach me about that. But it's a great tool. And in Ohio, we are really strongly suggesting for people to document throughout lifetime as much as possible, especially people with Down syndrome, but anybody, in this early detection and screening for dementia NTG form. And that form, it takes the big areas of life, right? The main areas, ADLs, communication, sleep, wake patterns, all that kind of thing. And it has you document at different times during a person's life, starting early on, is there a problem in this area? And then you have to actually say, has this always been the case, right? So if you don't start one till you're 50, you can say, has this always been an issue for the person? Is this always been an issue, but now it's worse is another option. This is a new symptom. We have not seen this before, or it's just not applicable. The person is fine in this area. So we are really working with our local county boards. We are trying to get our medical field, our county boards, are involved in most people with significant disabilities in Ohio, and their case managers are starting to learn about this. We're also talking to doctors about using it, and family members really to start just tracking. So that's been kind of a best practice. I hope that is being used in other places, but it's been super helpful. You can certainly find information about that on the NTG website. Specifically your question, Jen, around communication problems. That's obviously a real struggle for people, lots of people with intellectual disabilities. Even if they talk, they might not be able to share some of the more abstract type of thoughts or feelings or, all kinds of things. So in general, in the IDDD community, we really look to a team approach to, assessing where people are. It's very, very, very important that caregivers, anybody that knows the person, is involved in any of these assessments. Doing it in a silo with just the person, whether it's because their comfort level or an actual developmental delay or a communication disorder, you often are not going to get good information. People will often say whatever they think that you want them to say. So yeah, I can do that. Yeah, I can do that. Yeah, I can do that. Or the opposite. No, I can't do anything, very kind of. So interviewing caregivers in separate times is super important. Actually spending time with the person and observing the person, that is probably also really good. Now I know, for medical professionals, that might not always be possible, but for family members, for case managers, for social workers, that is very good information. And the more time you can spend, the better off you're going to be. And of course, working into that, like I said, that kind of exciting thing is that a lot of people that we work with do have people around them. So really identifying not just the person that brings them into the appointment, but also who else might I want to talk to that knows this person well, sees them in different places, so that we can assess those questions that you might not know the answer to. So really bringing in that team is super important, and to document who said it, when they said it, so that we can keep that then in and watch any kind of changes in brain health.
Great. Thanks. And Mike, I'll turn back to you. With your work with the American Indian and Alaska Native communities around a variety of issues, including brain health, what are some underlying principles to your work that might be able to be applied around brain health with other diverse or underserved populations?
One of my elders, Steve Chapman, who's an Ojibwe man from Minnesota, who guided me as we got involved in developing the public health roadmap for Indian country. When I met him the first time and talked about where I thought we were going to go, he touched his eyes, touched his ears, and touched his mouth silently, and then said, "What do you think I just said?" And I said that I should look and listen a lot more than I should talk. I think that's the principle that has underlied our work with tribal communities, is that we listen and look before we come in from outside with our prepackaged solutions, because they may not be applicable, they may not connect. There's a lot to learn. I think along that same line, I think we have to develop a respect for, there's different ways of knowing. The white Western medical world is full of data. The Alzheimer's Association Facts and Figures stands as a testament to the need for accurate and actionable data in this space, and met a need that existed long before that document came along in its annual version. There's other ways of knowing. American Indian and Alaska Natives are a microscopic percentage of our population, and when we do big public health surveys, frequently they're so underrepresented we can't get good data. What is other forms of data? Story, families, listening, all very important. I think a respect for sovereignty. A tribal nation is, in fact, in a nation-to-nation relationship with either state or national government. That is the law. And data sovereignty and sovereignty over over activities on a reservation or involving people who are identified with a particular tribe is absolute. So respecting that and trying to understand how that weaves into a pattern of collaboration that may be different than ways in which we do collaboration otherwise. Look, I'm an old community organizer. So I think the last thing I would say is I some of the solutions, some of the different ways of knowing some of the solutions, because healthcare is so localized in America, really have to come from the bottom up, and encouraging that voice to come up and to bring input even into national documents. We're in the process. This is a shameless plug, but this is the roadmap for Indian Country 1. We're in the process right now with the Alzheimer's Association, CDC Healthy Brain Initiative of writing roadmap for Indian Country 2. And the first step in the process is gathering the wisdom of the community, whether it's for case studies, what the state of things are, that kind of bottom-up approach, where we can hopefully take tools like CARE and the bottom-up approach and find some way in which they can mesh together nicely. So those are some of the principles that underlie the work. If you want to be effective, if you want to be ineffective, come in and create more moments of distrust, mistrust, and confusion and poor communication. When I was writing the first roadmap for Indian Country in 2018 into 2019, I can tell you I went to several tribal leaders and I got the, oh yeah, we know about Alzheimer's, and got shown the door, because before me there had been, for example, researchers from the city who came in and took samples and really never collaborated very well with the tribe or provided them information back. So I think it's attitudinally different. Bottom up is important, but respect. Carl's agreeing, which makes me happy.
I
Carl,
see
I
that.
lived in the Alzheimer's Association before Facts and Figures, so I respect it a lot.
And Mike, we respect your work with the Alzheimer's Association, so it's great to see you here. Sure.
Great. Such great information. Thanks. I love to listen to you, Mike. You're so passionate, so wonderful. Dan, what would you like primary care teams and others who work with older adults who have dementia to know about stigma and that combined challenge? You mentioned intersectionality of being LGBTQ plus and having dementia, so that combined challenge.
For the last 2 years, the Human Rights Campaign has had a formal partnership with Alzheimer's Association, really centered on education, awareness building. And through that partnership, we've hosted multiple webinars with individuals who have been affected by dementia and also identify as LGBTQ+. I've also had the pleasure and privilege to sit with an LGBTQ dementia support group, specifically hosted by the Alzheimer's Association, and hearing the stories. And what we hear often for folks in the community, and this is really transcends across the country, is that the coming out process as someone with dementia or as a caregiver of someone with dementia has a lot of similarity to their own coming out process as a gay person or as a transgender person. They lost relationships, they had to leave their work behind, they had a lot of isolation and fear, and often felt like they were the only one. But that being said, that changed on its head once they found community and recognized that there were many others in this journey. But I think the analogy of coming out, especially when we talk about other identities that can cause barriers to care or access to care, equitable care, really then puts it on the provider to actively seek out information, actively asking, as we've talked about, listening more, asking questions that are more open-ended as well to get a sense. This is a population that is twice as likely to age alone and 4 times less likely to have children. And as we know, a dementia diagnosis affects the person and their whole network. And so when we take in consideration this population, who often has chosen family members who may not have a legal relationship, as a primary care physician, primary care teams, really bringing up the conversation around advanced directives, powers of attorney, medical decision-making can be really critical for these older adults who are aging again within declining networks, social support networks, and networks that may not be legally recognized with the healthcare providers. So ensuring that we're having those conversations, letting people tell us who they are, and then equipping ourselves as professionals with those inclusive practices and policies.
So I keep hearing about let's listen more than we talk. I think that keeps coming out over and over. And I love the thought of the humility when Carl mentioned cultural humility, such an important concept. And I keep hearing that theme from you all. So we've discussed a lot of challenges. We've heard a few successes, but I'd love to dip into successes a bit more. Mike, what have been some of the success stories with the Indigenous communities looking at dementia issues that you might share?
I'm a storyteller, so look out. The Dementia Friends movement, or the Dementia Friendly Community movement, has been applied fairly successfully as a model of raising awareness by some of the tribes in the Great Basin. The Great Basin is basically all that beautiful territory that's desert and everything in between, going north from Las Vegas to Canada. Several of the Great Basin tribes, particularly the Pyramid Lake Paiute, have taken the Dementia Friends, Dementia Friendly Community model as a way of raising awareness on their reservation. The Greater Portland Area Indian Health Board, with support from the Centers for Disease Control, BOLD Alzheimer program, has initiated a number of public health strategies, not medical, but public health strategies in their membership tribes all over the Northwest. At the national level, the International Indigenous Aging Association, IA squared for short, because we have to make everything short, has developed has a BOLD funding at the national level and has a repository of everything that's been published by tribes for awareness and education for Alzheimer's disease. The Indian Health Service has now taken advantage of the fact that Congress has provided them funds for an Alzheimer program and is piloting a number of clinical programs on reservations. I would be remiss if I didn't also mention that the Older Americans Act Title VI program, which is the traditional services that we're used to from Older Americans Act, information, referral, respite. The Title VI program, its national staff, its regional staff, and its local directors have embraced being a resource in those tribes with Title VI programs, being a resource about providing information and referral about Alzheimer's. And last, on a policy front, I think it's important to point out that in several states with active state government Alzheimer plans, particularly Washington and Idaho, we have seen the direct participation of tribal leaders in developing those state government action plans and action items directly related to the differing needs, interests, and culture of tribes about incorporated, woven into state government Alzheimer plans. So there's a lot going on.
Very good. Carl, the Alzheimer's Association is partnering with community organizations to drive brain health in diverse and underserved communities. Can you share some success stories there?
Yeah, I tell you, Mike mentioned the public health model, which is applicable here. It is the, Alzheimer's Association trying to work with many, populations who are disproportionately affected by Alzheimer's or another dementia, underserved, and many times underserved, with the resources that we have with our organization, free resources on our website, or as you mentioned, Jen, with our chapters and the work that we do, physically in communities, and we need to do better in getting those resources out to all communities, particularly those that are hardest hit by Alzheimer's and another dementia. And then, combining that public health approach with what we mentioned around humility and trust, and the need to get to many, people in these communities. We've taken on a partnership, model. And Dan mentioned one earlier. We're so pleased and honored to work with the Human Rights Campaign, because that gives us the opportunity to work with, many in the LGBTQ plus community around the country, because they have membership and constituents who trust HRC, the Human Rights Campaign. And if the Alzheimer's Association, can present ourselves to be trustworthy and can share our resources together with HRC, then we can expand the reach of people who can benefit from our resources. So, that's one example of how we've been successful working with Dan and HRC. We've also worked with a production company, and and I tell you, my training is in public health, and I never thought that I'd have an opportunity to be a executive director of a stage play, but this play includes really important information about Alzheimer's and dementia, why it's important for everyone to participate in clinical trials, and how to engage with the Alzheimer's Association. So we partnered with Garrett Davis Productions and Films, and they've been doing these types of health-related community theater for years. And we developed Unforgettable, which is a live stage play about Alzheimer's caregiving, crafted to educate and entertain. We say edutain, in ways that resonate with, culturally, with communities that have been underserved by our resources. And so since the launch of Unforgettable in July of 2022, the association has reached 10,000 new constituents, primarily Black, African American, Hispanic, Latino constituents, made 700,000 new media impressions, right? So that means that people are seeing, what Unforgettable is, hearing about the Alzheimer's Association, going to our website to get information, and we've worked with 150 local and national partners. And that was all through a partnership with the production company. So we really believe in the priority of partnership, and it takes time to engage and find ways to work together to establish trust, right? To be trustworthy, it takes time, but once we get to that point, we can work together to get our resources to the communities that need us most in. So, success stories, and looking forward to Unforgettable in 2024. We just announced 10 new locations for 24. We're starting in Miami in March. So please look out for ways to work with us and to come in and see the live stage play Unforgettable.
Great. I look forward to seeing it, that's for sure. Lisa, let's turn back to you. We have had the pleasure at GSA of working with some colleagues, including you at the Ohio Association for County Boards of Developmental Disabilities, to develop a soon-to-be-released new resource from GSA, and that's called Addressing Brain Health in Adults with Intellectual Disabilities and Developmental Disabilities, a companion to the KAER Toolkit for primary care providers. We mentioned Mike talked about IA squared and said we need shorter names. We could probably use one there, right, Mike? But primary care teams now are really, they are the primary audience for this tool, but we really think it will prove useful for others working with individuals with ID or DD as well. How might direct support professionals and others use that new resource?
Yeah, Jen, thanks so much to GSA for picking Ohio to work on this project with. It has really been a great thing. And before I get into the companion tool, I do want to give a huge shout out to the Dementia Friends, because Ohio has been super successful in the IDD community with the Dementia Friends. And there's a special workbook for people with IDD and dementia friends. And so that has done a lot of what Mike was saying, where we are getting a lot more people talking about dementia and accepting it and more respect and acknowledging it and not being afraid to talk about it. So check out that Dementia Friends if your state hasn't done it yet, or, you know, to develop more of that, because that's been really a big success. And it really is what kind of brought me in a roundabout way to GSA. I got involved in Dementia Friends, which then got me involved in the National Task Group on IDD and dementia. And then I got involved with the Gerontological Society. So yeah, we are so excited to launch the KAER. I'm just going to call it the KAER IDD companion tool, because I can't say all those other words. Jen knows I say it wrong every time. But we launched it with a lot of county board staff who, again, are more the case managers involved with people who are eligible for services through the developmental disability system in Ohio. And there was a lot of excitement in the room about just having something that we could share with families, with DSPs and caregivers, and with the doctors. I mean, there's a lot of the folks that we work with that have developmental disabilities do have somebody else going to the doctors with them. So we want people to know that they can take this and share it with their doctors. They can have it, they can read it. There's a lot of great information in it about different kinds of symptoms and signs and the challenges and what maybe actions to take. I think an interesting thing that I learned when I was going through the KAER Toolkit with GSA was that, and even Dementia Friends, the IDD community has spent a long time talking about really challenging people to get out into their community and, you know, always moving forward and all that kind of stuff. And when you learn about the dementia and folks that have been diagnosed with dementia or Alzheimer's, you learn that you need to start kind of maybe coming back in a little bit and making things a little bit more, you know, comfortable and not necessarily doing all the challenging. So for us, I think that KAER Toolkit, along with some of the other information that we have, is going to be really helpful so that we remember that people, just like anybody, changes throughout their lifespan, that as people are aging and we do develop dementia or Alzheimer's, that we might have to change the way that our support services are around them. And that toolkit is going to be really helpful to see what are we looking for, you know, what kind of surroundings could we do to make, you know, make people more comfortable, more safe, and all that, and still stay at home as long as they can in their homes. So that's really, we're just super excited about getting the word out. And I'm really excited that just recently we got the medical director for the state of Ohio's Department of DD involved, and we are going to be presenting that. Jen is going to be wonderful in Ohio, presenting it to her and some of our leading doctors and medical professionals in Ohio at a healthcare equity think tank that goes on monthly in Ohio. So we hope to really, that's going to be 2024, is going to be trying to get that out to the people that need it the most. And I'm so excited to be part of it. So thanks, Jen.
Thank you. And something that I think we've seen come out of that new toolkit is kind of the county level. I've heard from folks in Ohio that aging services was over here and IDD folks were over here. And now they're saying, let's come together and learn about this resource together, because we're all, you know, these are services where both support agencies now may come together and support that individual with IDD that's aging. So it's been really neat to see that kind of cross-agency collaboration. That's really exciting. So
Yeah,
Dan, before we close, I'm going to give the last question to you, and that is to ask if there are resources that you can suggest to help provider teams seeking to provide more culturally competent care to individuals from the LGBTQ plus community.
Thanks, Jen. I think as we continue to have this conversation about welcoming spaces, culturally competent care, it's important that we really push and operationalize as well as quantify that as well. So I'd love to uplift two projects that the Human Rights Campaign has run for several years now. For providers that are associated with a larger healthcare entity, hospital system, our Healthcare Quality Index is our national LGBTQ benchmarking tool that evaluates healthcare facilities, policies, and practices as they pertain to equity inclusion of this population. It's a validated survey. We're closing out this HEI 2024 survey with over 1,000 facilities participating across the country. We do this work also within the skilled nursing, long-term care, residential long-term care field, senior housing. Really, how can we support these providers to ensure that their environments are inclusive? It's unfortunate to see situations where an individual may see a pride flag, but their non-discrimination policy is not inclusive of sexual orientation or gender identity. So we really work towards building those foundational practices of inclusion that's so critical, especially now as folks feel more comfortable in trying to find inclusive and safe housing. We do that work in partnership with SAGE. SAGE is the largest LGBTQ aging organization. It's been around for about 40 years. They oversee the National LGBTQ Resource Center that is funded, and that could be at lgbtagingcenter.org. Also want to highlight continuing education is such a critical piece. The Fenway Institute has a project, the National LGBTQIA Health Education Center, where they have many on-demand webinars on a series of topics. It was mentioned earlier, the Project ECHO. They have a Project ECHO model specifically surrounding trans healthcare for folks that are interested in providing gender-affirming care. More information on our projects can be found on hrc.org/LEI. Really to highlight, I think when we talk about this topic, it affects all of us, and really recognizing the importance that we have as people to people of listening, of creating space for folks to share who they are, and in turn we can provide that much more in tune and humble care as we approach all these populations across the spectrum.
Thanks, Dan. And I think that's a great way for us to end our session. We've talked a lot about trust, humility, listening and learning, and also being innovative and working together to really find solutions. And many thanks to you all for joining me today, for sharing your insights. This has been a great discussion. GSA sincerely appreciates your great work and your partnership to share your work with our members. We also appreciate the support of Genentech, Lily Oatskin, and AZI for our KAER Toolkit and for this momentum discussion. And I appreciate our audience for joining us on this webinar. Thank you all so much.